The delay of this afternoon session. The first speaker for this session is very well known in the field of echocardiography. He was the president of TomTech, and everyone in echocardiography knows what TomTech means. Dr. Bernard Mumm, he is going actually to join us now, and he's going to talk about artificial intelligence in echocardiography. He is a pioneer in digital technology and in different models of echocardiography. He is really a great genius man. He is going to tell us his experience in artificial intelligence in cardiology. Thank you. Dr. Bernard.
Dear Chairman, thank you very much for a very kind introduction. Just to check, you can hear me, you can see my presentation. Can you confirm, sir? Can you hear me?
Yes, doctor, we can hear you.
Yes, we can hear you.
Okay, very good. So, ladies and gentlemen, it's my great pleasure to give this lecture about artificial intelligence in cardiology at the Almosa Echo Conference, and I would like to thank the organizers for giving me the honor to invite me. I've been in Saudi Arabia a couple of times in the past before the pandemic in Riyadh and Jeddah, so this time only, unfortunately, in the virtual format, but anyhow. So my disclosure is I'm a research consultant for TomTech Imaging Systems here now in Munich, Germany. So if we talk about artificial intelligence, I think it's anyway already around us in our daily life in cars. So we already have cars driving automatically, following the car in front of us, holding the line and so on. And pretty soon we will have completely autonomous cars driving around. Google search is full of artificial intelligence. Our smartphone is full of artificial intelligence. So it's nothing new. It's around us, even if we do not recognize that in our daily life. But how is it in medicine? And I think there is no day without news about artificial intelligence in medicine, everyday new publications, new facts, how good AI is working in medicine, and that AI is always better than human beings. So in our area, AI in cardiology. And I use now artificial intelligence to ask this question. So there is a new chatbot called ChatGPT by a non-profit organization called OpenAI. And this tool is really amazing. So I entered this question into the tool. I entered the question, give me an overview about AI in cardiology. And within 1 second, it gave me this answer. AI is being increasingly used in cardiology to assist the diagnosis and management of cardiovascular diseases. And then within the next second, it gave me even all the details, like AI will be used in image analysis for automatically analysis of echo, CT, MRIs, and so on, or to come up with predictive event, like a heart stroke, heart attack, or so on, or that it can help in personalized treatment in order to identify the best treatment for a specific individual patient, but probably most important, to do a data analysis on so-called big data, which is not possible anymore by human beings, to automatically analyze a large amount of data to find patterns and identify probably patients for a specific treatment. So, and this summary as well is given to me by OpenAI, that AI in cardiology has the potential to improve the accuracy and efficiency of diagnosis and treatment. And I must say this is a little bit frustrating, because I know that that all these points are true, because I had basically nearly the same points in my previous lectures as a slide, but it took me a couple of days to put that together, and this AI bot gave it to me within probably 3 seconds. So what's about cardiac imaging, and that AI is so important as well in our area, showed that the European Association of Cardiovascular Imaging, they made a special session about artificial intelligence, an online session at last year's December meeting, the online meeting. And they showed then how AI can revolutionize cardiac MRI or cardiac CT with all new algorithms here, or even nuclear medicine. But for sake of time, we will look for it. Use of AI in echocardiography. And this was nicely summarized by this article published in Chase last year, telling us the future guidelines for AI in echo. And this group of authors came up with this 5 points here, that AI will change the world in image acquisition by helping us, or the cardiologist, the sonographer, to come up with better image quality during the acquisition, then an automatic interpretation of the data with an automatic measurement like auto-EF, auto-strain, or all the cardiac measurements will be done automatically. And this is already reality, and I show you some examples a little later, and so on, diagnosis and prognosis automatically provided by the AI algorithms. There was a very nice lecture, the famous Feigenbaum lecture at 2 years ago, American Society of Echo Conference, and Dr. Cuddy, he summarized that very nicely, and he called it analytic intelligence. So what does that mean? So in analytic intelligence, we do not look at one specific question like what is the data we get from imaging, echo, MRI, CT, and so on. What is the data we get from the pathology lab or the blood tests and the lab diagnostics? And all these data are now put together in this analytic intelligence cluster-based algorithm, and then the algorithm can look at all the data at the same time. And an example for this patient here, giving us then the probability of a risk that this patient needs to take ACE inhibitors or something like that. So very powerful tool in the future. Another nice publication here by the European Heart Journal, showing us the pathway to the future of cardiovascular medicine. And what they said is that what are the 4 major aims overall in medicine? To predict and diagnose a disease, understand the history of the disease, and then optimize the prevention and management. And all these 4 aims, AI will increasingly be valuable in every day's work for the physicians in the future. And why do we really need new tools? If we look to the problem of medical data, so right now, a lot of the data, over 75%, are unstructured of all the patients. And you get a lot of data for every patient, more and more every year, image data. Think about the high-resolution CT scanners, how many images you get per scan, and you are not able to look at all the images anymore one by one, or the measurements, biomarkers, lab data, risk factors, trending, and so on. So there will be, or is already, an overflow of data, and there is a less and less time really to treat the patient actually, or to look at the patient, because you're working with the computer. And I believe that AI will be the solution here to automatically extract the information from the data, do automated measurements, and not by hand anymore, means much more reliable, much more reproducible, and even very important, create clinical findings completely independent from the physician's experience. So an example, if we look to an experienced hospital like the Almosa Hospital here, all compared to a very small rural hospital, the algorithm will always do the same result independently of the local physician's experience, which is a very beneficial situation. So let me share our vision of an automatic analysis in echocardiography, and a lot of these things are already working and implemented. It's not future. So the acquisition is done on the ultrasound system by hand, and but assisted by AI. And as soon as all the data are acquired, they're automatically stored to your hospital cloud storage, or even to the real cloud storage. And then as soon as they are there, an AI algorithm, an AI server looks at the data, is analyzing all the data, is doing all the automatic measurements on the data according to the predefined, in example, ASE or European Association guidelines. And then the results are there. And at any time, seconds after the acquisition, wherever you are in the hospital, you can look at the results, probably already at the diagnostic proposal, and analyze that. And really soon we already have such devices where a probe is connected to a smartphone, where even the acquisition is guided by AI, and the remote reading wherever you are in the hospital on your tablet, an example, it helps you to assess the data, the results, everywhere, anytime in your hospital, seconds after the acquisition. So if we look to the echo workflow here, image acquisition, as said before, even here we develop tools which are doing an auto detection of views, like automatically telling us this is a 4-chamber, this is a 2-chamber, 3-chamber view. And here's an example of such a tool called Echo GPS. And here you see a position sensor on the probe and a smartphone. And as soon as the algorithm, the AI, is identifying a good or perfect, an example, parasternal long axis view or short axis view, the view is locked, and then the guideline tells you go now to the next view and so on. So this will help really to acquire much better quality data, which are then used for an automatic analysis. So the measurements are done completely automatic, and this is already reality today. And we published that as a TomTec group together with the World Alliance of Societies of Echocardiography already last year, 2 years ago. And here, with this algorithm, we could automatically recognize all the 18 standard views, 4-chamber, 2-chamber, and all this data are then loaded into a convolutional neural network AI algorithm, and then all the related measurements on the images have been done completely automatic. 2D measurements, tissue Doppler, Doppler, continuous wave Doppler measurements. And the results have been then published here 2021 by this group and the World Alliance of Societies of Echo. And the results are very promising. And you see that the first step here to recognize the standard views could be done with an accuracy of 91%. By the way, if you look to all the publications about AI in many areas in medicine, always this is a typical accuracy, over 90%. And then the automatic measurements could be done at least with a similar accuracy like experts, because we do not have anything else to compare it with than experts. So very promising, and this is already reality. What do we mean if we talk about artificial intelligence? This is just a term more or less to tell us, and it enables a computer to think, but a subset of AI algorithms is called machine learning. And here we create rules for the computer to learn from the data itself. And another subset of deep learning, machine learning, is deep learning. And here with deep learning, more or less, the human brain is mimicked with so-called artificial neural networks, which are now capable to learn from data in an unsupervised or supervised way. And this is probably the most dedicated algorithm for medical data. Most of our algorithms are deep learning algorithms. So how do we train the machine, this deep learning algorithm? Here in this unsupervised learning way, we give just an unstructured data, like this group of people, into the algorithm, and the algorithm by itself is then finding clusters like the green cluster, the blue cluster, the red cluster, and so on. Or here on the right side, so-called supervised learning, where we tell the algorithm with thousands of images. An example, this is an image of a red apple, this is a green apple, this is a banana. And thousands of times, and then the algorithm is creating by itself a model predictor and can do it then automatically. So in our area, we do the same. We tell the algorithm, these are 1,000 examples of a 2-chamber, of a 4-chamber, of a 3-chamber view. And by that, the algorithm learns and can do then this detection automatically.
Dr. Bev, now
Sure.
3 minutes, please.
Okay, yes.
Thank you so much.
There are limitations, and at the American Society of Echo last year, Dr. Pendin, he showed this slide saying if we would only use AI in the future, nobody would understand if a result of measurement physiologically would make sense. So, and he proposed then the term real intelligence as the combination of AI and human intelligence. So to come to the end, let me show you an example. As I know, Saudi Arabia is football, soccer addicted, how AI can make mistakes. So this AI algorithm was controlling the camera of a football game, and the algorithm was trained on this ball. But then, unluckily, the line referee had as well a bald head, no hairs, so it looked like the ball. And let me show you what happened then. During the entire game, the automatically AI-controlled camera was always moving away from the ball, always back to the head of the referee. And so people always missed watching this TV, the soccer game, the goals, because the camera always was going back to the ball. And this shows if the algorithm is not trained well, mistakes will happen. And just assume this would happen during the upcoming game here from Cristiano Ronaldo and Messi very soon, I think in Riyadh. And you would be upset not seeing the nice goal from Ronaldo. So this brings me to my end and my take-home message. I'm very confident that AI will help to make the diagnosis faster, more precise, more reliable, more reproducible, and help the physician to put more time on the patient and hopefully have more empathy shown to the patient and have more time for really complex cases. So therefore, it will help physicians to improve patient care. So with that, I would like to thank you very much for your attention.
Thank you very much indeed for this excellent lecture. Unfortunately, because we are lagging behind on the schedule, I think there will be no questions. So thank you so much, Dr. Bernard. Thank you, very kind. We can move now.
Okay, so we will move to the next speaker, Dr. Fatima Gaddoura, who is a non-senior consultant non-invasive cardiologist. Dr. talk about assessment of multi-functioning mitral valve, bioprothesis, and transcatheter mitral valve in valve.
Assalamu alaikum. Thank you for the organizing committee. Thank you for Dr. Ala and chairpersons. Unfortunately, I'm supposed to talk for around 20 minutes because I have two topics, but I was told by the organizers, yes, that I have to go a little bit lower. So I'll try to skip as much as I can from things that, so allow me please if I go fast and I skip things. So I will talk first about the mitral valve apparatus, and just to know for the people, juniors, that it's combined from the annulus, leaflets, chordae, papillary muscles, and left ventricle. This is the views that we see it with the 3D, where we're seeing the anterior mitral leaflets and the posterior mitral leaflets with the multiple scallops present there. What were the indications for the mitral valve replacement by prosthesis or mechanical extravalvular stenosis, regurg, or endocarditis? And as you could know, you know all that the incidence of having mitral valve prosthesis, bioprosthesis, and usually it's common between 20 to 40 and above 60 years of age, while in the middle it's more of a mechanical prosthesis. Those are the types of the prosthetic valves, the bioprosthesis, stentless, and the stented valves. And they have, this is the normally functioning valves with the normal aliasing of the prosthesis without having any obstructions and freely mobile leaflets. And there is an intravalvular mitral regurg, which is usually of normal variant. This is the type of valves that we see in systolic and diastolic from the atrial side and ventricular side. And this is, you could see that there are 3 scallops from the atrial and from the ventricular sides, where you can have the stents also protruding and the annulus. The way to assess the hemodynamic status of those valves is to do the LVOT measurements and be always careful to take it from the inner edge to the inner edge. And if there is any calcification, skip that calcification and go back to the mitral annular area and check the LVOT BTI, which is very essential in those patients to make sure to take it not over or under signal dose, because it will be an artifact and will not be appropriate. And the second thing you have to take in those patients with the mitral valve prosthesis is a continuous mitral valve Doppler to have the TVI. According to this, you will go and calculate the LVOT stroke volume from the area and the VTI. And with this, you can get the mitral valve area by dividing the LVOT stroke volume over the mitral VTI. One of the things that we have to monitor on those patients with bioprosthesis and very essential is to have the Doppler velocity index and divide the mitral VTI over the LVOT VTI. In opposite to the cases of the aorta, where you divide the LVOT VTI over the aortic valve. So you have to be careful in this one. This is another way of assessing the mitral valve prosthesis by PISA and by the vena contracta. Those are the parameters which we will go after later on over it. This is the modalities that we screen the patients with. It's usually the transthoracic and TEE to evaluate for any patients having any valvular dysfunction. However, the CT and the PET scan is a very important and essential, especially in the cases of endocarditis. It has been shown that the PET scan is a valuable one where it can predict the cases of progressive degeneration of the prosthesis, even when you have a normal echo and CT. So it is essential in certain cases. Patients present usually with the acute heart failure from regurgitation or obstruction. They can have embolization from thrombosis or endocarditis, and they can present either early with a structural failure of the valve, paravalvular leak, early infection, or prostatic mismatch. Venous formation can occur also at the later stages with thrombosis and dehiscence. This is very nice article, has been elaborated to tell you exactly the steps that you go by in order to evaluate the patients for valvular dysfunction, the bioprostatic valve dysfunction. And they have divided them on non-structural and structural, and this will go on in the coming few slides. This algorithm, it looks busy, but it is very nice stages that have been elaborated to tell you first that you have to assess the hemodynamic status, the etiology, and then the follow-up of those patients of bioprosthesis in order to reach a conclusion of failure or dysfunction of the valve. So when we are assessing the hemodynamic status, the first one is the DVI, which is the Doppler velocity index, if it is more than 2.2, if the effective orifice area less than 2, and if the mean gradient more than 5 with minimal MR. The second stage is to know the etiology. As you know, there are multiple causes for it: wear and tear, calcifications, pannus formation, endocarditis, and thrombosis. And with this, they have divided the non-structural nicely into paravalvular leak or a prostatic mismatch. And in the cases of prostatic mismatch, which we have to be careful, we have lots of cases that is underdiagnosed. And they have placed numbers where it is severe in patients below 30 and above 30 kilogram per meter square, where you have it less than 0.9 or 0.75. Moderate prostatic mismatch, it is common and it is underdiagnosed, 20 to 70%. However, the severe ones, which needs to be alerted about, is around 2 to 10%. And the presence of severe mitral prosthesis mismatch, it does affect the outcome and not causing a regression of the pulmonary hypertension. This patient, you could see it here, it looks normal, right? Agree? Leaflets are moving very nice. We'll get the next one. You could see that there is something is coming from the side. So I have to be alerted that there is some MR is there, and I have to check in tilting on the same angle. While I'm still in the zero, I just tilt to get that MR seeing it. Exactly the same case as the Dr. Tariq has presented, you may be fooled with it and not seeing it. And you could see here it's a tilting of the valve with evidence of significant MR, so a case of paravalvular leak. And you could appreciate this as have shown by Dr. Hani at 1 o'clock. You could see nicely the defect. Second case where we go for structural, it is wear and tear of the valve, leaflet disruption, flail leaflets, leaflet fibrosis, or stress fracture. And this one, you could see it very nicely. I need your comment in one thing here. You could see here the leaflet is a flail, right? And the medial one. And you could see there is MR. I want you to compare this one over this one. Okay? There is a flail also leaflet medially, and there is a significant MR showing, right? What's the difference between both? Anyone can tell? Additional? No, this one. From where the MR is coming? This one. Is it coming from the valve itself, from intravalvular where the connection is the communication? Or is it coming from, can't you see it is coming from the base of the mitral? It's not coming from the coaptation. It's not coming, okay? Right, so it's not, so this is one of the things I was really staying with this echo just to see from where it is coming. And when we see it here with the mitral, despite the echo drop signs, you could see that there is some source of dehiscence of the valve itself, like a torn area. Oh. Here. So you could see it that there is an MR coming from there, and when we did surgery for this patient, it's a torn cusp tear totally from the base, okay? And this is very rare presentations of those patients. The next one is just a mitral valve which is not working. This patient was critically ill and showing obstruction and significant mitral regurg, intravalvular. And this is an obstructive type where you could see that there is one of the two leaflets are not moving and only one leaflet is moving and causing an obstructive early degeneration of the valve. The next step is thrombosis and endocarditis. And it's a bit difficult sometimes to differentiate between both. And this is the rule here where you can have the PET scan in it, because it can show an uptake increase more with the cases of endocarditis to differentiate between both. However, the bioprosthetic valve thrombosis is something also which is also common and need to be looked at, because those patients, they can develop thrombosis, especially in patients with atrial fibrillation, previous thromboembolic events, and hypercoagulable condition. And the predictors has been shown that if he has an mean gradient which is increasing more than 50% with subtherapeutic INR. This is just to show you how difficult it is to tell. This is a mass on the mitral valve prosthesis. After 1 year, patient stopped till anticoagulation, and we don't know whether it is endocarditis or thrombosis, and patient cleared after taking antibiotics and antithrombotic agents. This is a mass which is extending from the mitral, from the LA, all over down to the prosthetic valve, causing a restriction of the posterior mitral leaflets. Stage 3 is the follow-up. Follow-up of those patients is to see the structural deformation of those patients, whether it is paravalvular or non-valvular, and if there is any progressive deterioration in their DVI, more than 20% or more than 25% in their mitral valve area reduction, or increasing in the MR with the increase in the gradient more than 10. The stage that we reach at the end is to document that this patient is having a bioprosthetic failure, not only dysfunction. It depends on the criteria 1, 2, 3. The first one is just any bioprosthetic with a new onset of symptoms, whether we have LV and RV dysfunction with significant pulmonary hypertension. And irreversible stage 3, and criteria for 3 is the one when you have failure and death of the patient. Conclusion for these patients that both surgical and transcatheter mitral valve prosthesis has limited durability. However, the definition of structural dysfunction requires confirmation of imaging, permanent changes in the structure of the leaflets, and in the hemodynamic effect. And do not consider only the death of the patient is because of the failure, because there are lots of cases for failure even when you are causing intervention. How many do I have left? 3 minutes. I'll go quickly on the 3 minutes مع 10 and 15 هدول
إيه.
من غير 4 زيادة. طيب.
4
Okay.
minutes عشانك.
Okay. So this is a transcutaneous in comparison with the surgical. This is very important because during the last decade it is progressing very quickly, and transcutaneous is increasing. And when they compare the transthoracic, transcutaneous to the surgical procedure, they have more high STCS score, less total procedure time, less coronary bypass time, less shorter ICU and length of stay. They have less new AF. They have less major bleeding and ventilation. So in general, they have a better outcome than the other one. And of course, you go for it because you are trying to avoid reoperation and excavating of the mitral valve and shorter stay in the hospital, except as we discussed today, patients with a prostatic endocarditis or LVOT obstruction or combination with CABG and other valves. Those are the valves that we are talking about. One few things about the choosing of the size of the valve. Very important to know that the label size is not the size that we are using for the valve in valve, and it's the true one is the one which is CT guided or by the TEE. And of course we have caveat for this in order when we are doing it, in order to measure the inner area for the mitral valve by prosthesis to determine the size, and you have caveat with the CT and with the TEE, but you have to combine both together. The oversizing is very important. You have to make sure you're not causing stenosis, you're not causing regurg, and at the same time, not to make sure that you're not causing any embolization or migration, because the closure pressure over the mitral valve leaflet is much higher than the aortic, so it can cause it much more. This is very nice slide just to tell you exactly what to do in those patients. When you are deploying the valve, very important to make it 80 to 20, a ratio between LV and LA in most of the cases. And if you migrate a little bit, propagate into the LV, you cause LVOT obstruction. The flaring of the mitral valve by prosthesis, the initial one, can cause this also LV obstruction. If the angle which we are measuring in the TEE less than 115, this increases the risk of having LVOT obstruction. Septal thickening more than 15 also can cause this. And a very important one, the predicted new LVOT area, which is measured by the CT when you are placing the mitral valve in valve, it's not to be less than 2 centimeter. The area also which is important for us to look at, just a minute please. الheight of where the procedure, our rule in those patients is to make sure that the height where we are doing the transseptal perforation is to be around 2.5 to 4 centimeters in general. There are 2 papers, one of them I'll show you, transapical and transseptal. The transseptal has a much more popularity with less side effects, less perfusion, conversion to surgery, and all-cause mortality is much better with the transseptal over the transapical. And the 5-year, this is very important one to show you just how it is for 5 years outcome of those patients. They have noticed that the transcutaneous is much better per mortality in the first year only. And then it flip over and cross over in that one and become, at the end, the surgical cases have better outcome than the transcutaneous. They have elaborated in this that most probably because the baseline for the transcutaneous patients having elderly ages with more chronic disease and significant pulmonary hypertension. However, the hemodynamics of those patients were almost the same between transcutaneous and surgical. Transcatheter mitral valve and valve preferable to reduce surgery should be the standard of care. Patients who have failed surgical prosthesis and who have favorable anatomy, you have to have a good planning, and it's critical to evaluate the valve size and LVOT obstruction risk. Thank you.
Thank you very much. It was very excellent talk. And now we have a very interesting talk from Dr. Mustafa Al-Rifai. He's a consultant cardiologist in Saud Al-Batain Cardiac Center, and he will enlighten us with an interesting case of TE cases. Please, Dr. Mustafa. Your time.
خليني اشغلك شوي. خلي بعد تايمون.
نتغير فيها خليها على
لانه والله
لا ارجع بلاي افتح بعدين نروح الكلينيكال كليرة. طيب السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Ala. Thank you for the organizing committee for giving me the chance to present in this prestigious meeting. I will be fast and to the point. So this patient, he's a 57 years old male patient. He's a known case of long-standing hypertension, diabetes. He presents to our center, Al-Batain Cardiac Center in Dammam, with prolonged chest pain. He was playing card with his friend. Suddenly he got chest pain, severe chest pain. So he came to our emergency medicine. So he had ECG, which shows significant ST depression in lead V4, V6, and his troponin was elevated. So he was given nitroglycerin, IV nitroglycerin. So his blood pressure dropped from 150 systolic to 80/50, and he has pulmonary edema. So he had chest pain, ischemic chest pain, ECG changes, elevated troponin, hypotension, pulmonary edema. And clinically, he has band systolic murmur. He had systolic murmur at the base, and another apical systolic murmur grade 3/6. So with this clinical scenario, and almost cardiogenic shock, and he's very sensitive to nitroglycerin. So what will be the next step to do? Next. So where to go? To admit him to CCU, or to take him to the cath lab, or to keep him in emergency room with some supportive measure? Stabilize with what? With inotrope. So we give him inotrope. So we need to raise the blood pressure. So his blood pressure 80/50. He came with a blood pressure 150 with a small dose of nitroglycerin. His blood pressure dropped to 80, 70, 60 systolic blood pressure. So we give him inotrope. Vasopressor. So he get worse. Cardioversion. Why? No arrhythmia. So you want echo. Okay, we will show you the echo. So this is his echo. He has good systolic function, right? Dilated left atrium, maybe because he is long-standing hypertension. He has LVH, hyperdynamic basal part of the septum, good RV function. Okay? So there is turbulence. Okay, so the money is here. So SAM. So significant SAM, and this explains his systolic murmur at the base of the heart. So significant SAM with, okay, now you can see two turbulence, one in the LVOT, one in the mitral valve. So he has significant LVOT obstruction and significant mitral regurg. The mitral inflow looks okay, again, same. Okay, so this is the gradient. We got significant gradient with dagger shape sign in the LVOT. Okay, so a gradient, we got mean of 105. So what will be the next step? We give him fluid, we give him normal saline. So the treatment, he's in pulmonary edema. So not diuretics, not inotrope. So the treatment is fluid, normal saline, plus beta blocker. Yes. So then what we should do next? So we take him to the cath lab. So this is his coronary angiogram. So he has tight lesion in the LAD and very tight lesion in the LAD and also tight lesion in the circumflex. So now for our heart team discussion, what to do? We have a patient with acute coronary syndrome, maybe non-STEMI, significant mitral regurg, significant LVOT obstruction. So he go for surgery, for mitral valve replacement and CABG. This is part of the heart team. They are advocating this, or to go for BCI to the LAD and to the CIRC. So who will be with the BCI? So we did BCI to the LAD and to the CIRC. So now we are interested to see the echo after BCI. So you see the turbulence in the LVOT disappear. Now maybe there is some mild SAM, mild MR or no MR. After now you see here the abnormal relaxation, before maybe pseudo-normal, and you see the gradient now came to 13/8. So the LVOT obstruction disappeared, the MR disappeared, and patient did well without the knife of the surgeon.
Three minutes يا دكتور.
3 minutes? Oh. طيب, where is the IT? Can I change the... So I need somebody from the IT? Okay, so I'll give you... I have another 10 cases. Next presentation, the other presentation, quickly. Interesting TEE. Close. Interesting TEE cases. Mustafa, Dr. Mustafa, yeah? Open Dr. Mustafa. Close maybe this, or you go.
Representation of acute?
Not this one. There is interesting TEE cases.
Where exactly is it?
You should put it under Dr. Mustafa.
It's already, this is the folder.
Only one? No. Interesting TEE cases. Oh, this one. Interactive. Okay. Play.
They all?
Play. When you get a play. One case, I will present it in 1 minute. into, yes, yes, play. If you see play, see something, play this one. Last one. Okay, I'll go quickly. This is 80 years old male. He came with left ventricular failure. He had severe mitral regurg. Clearly, you can see myxomatous mitral valve with severe MR, with significant pulmonary hypertension. So he underwent surgery in our hospital, mitral valve repair. Okay, this is before surgery, severe MR. Oh, no, this is not the one, huh? No, not this one. Yeah, this is the one.
أيوه.
Anyhow, this is a patient who had mitral valve repair, and he had severe SAM with LVOT. Okay, so this is the first echo intraoperative TEE after mitral valve repair. You can see significant SAM with significant LV turbulence here. Yeah, you can see both the posterior leaflet, the anterior mitral leaflet is long, and so what the surgeon should do? I did not accept this LVOT obstruction. I told him this is significant LVOT obstruction, significant SAM. So he took the patient back to the pump, and he did one step. Yeah. So he did one step. So what is that step? No. We use all the tricks. It didn't work. Hmm? No. No.
عمل مايومكتومي ولا ايش؟
No.
Stopped inotropes.
He stopped the inotrope. He gave fluid, beta blocker, all the tricks. The gradient was still there. He did surgical maneuver. He did what we call sliding annuloplasty. So he make it smaller. So the problem is the posterior leaflet is very long, and the anterior is also long. So this is a predictor for SAM after repair. So he make the posterior leaflet short, very short. Then the SAM disappear and patient did well. Thank you
يعطيك
very
العافية
much.
دكتور. Thank you so much. Thank you دكتور مصطفى. We'll move next to the role of echo in oncology patient مع الدكتور
Okay.
دكتور عبد المجيد consultant in King Fahad Special Hospital في الدمام. تفضل دكتور.
السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Jamila. So today I will present, inshallah, in probably 10 or 12 minutes, the role of echocardiography in oncology patients. So I will talk briefly about the epidemiology of chemotherapy-related cardiac dysfunction, different complications of chemotherapy on the heart, definition and types of chemotherapy-related cardiac dysfunction, assessment of LV function and chemotherapy and rule of strain with chemotherapy and diastolic dysfunction and RV dysfunction during chemotherapy. So generally, data are lacking on chemotherapy-related cardiac dysfunction. It's estimated that incidence is about 3% on those patients who receive a cumulative dose of anthracycline of 400. This increases to about 7 to 18% on higher cumulative doses of anthracyclines. But in oncology studies, the prevalence is significantly higher. The report says that it's probably more than 50% of cancer survivors exhibit some degrees of cardiac dysfunction. And after 10 to 20 years of chemotherapy, 5% of those develop overt heart failure. There are different complications, and all comes under name of chemotherapy-related cardiac dysfunction. One of them is the myocardial dysfunction with heart failure, which is the commonest, and we all know about it, related to anthracycline, anti-HER2, the vascular endothelial growth inhibitors, cyclophosphamide, and others, vasospasm and vasoocclusion resulting in angina and myocardial infarction, valvular heart disease that is caused by radiotherapy, arrhythmias, which is also caused by anthracyclines and TKIs, arterial hypertension, which is by vascular endothelial growth inhibitors, peripheral vascular disease, and pulmonary hypertension. So if we come to the definition of cardiac related chemotherapy, cardiac dysfunction, we see like a lot of definition in multiple trials. And they all play around with, main thing is the drop in ejection fraction, ranging from 45%, 55%. The definition from ACC is a definite cardiotoxicity if you have a drop of more than 10% and percentage value of 50%. This definitions in European is 53%. And probable subclinical cardiotoxicity if we have a decline by more than 10%, but the value is higher than 50%, with an accompanying decrease in GLS more than 15%. And the possible subclinical cardiotoxicity if we have a decline less than 10% and to a value less than 50%, or a GLS drop of 15%. This value also is 12% in European guidelines, but they are all comparable numbers. We have to recognize two types of chemotherapy-related cardiac dysfunction because their prognosis, their pathophysiology is different, and the treatment and the way we deal with chemotherapy-induced cardiomyopathy is different. So doxorubicin, which is the anthracycline, type 1, and trastuzumab, which is anti-HER2. So in anthracycline, usually new onset of heart failure and LV systolic dysfunction. So usually those patients comes with symptoms, while in anti-HER2, usually they are asymptomatic. And the dose effect is usually cumulative, dose dependent, while it's not in anti-HER2. And the clinical course may stabilize with heart failure therapy, but underlying myocyte destruction is irreversible, and that is the main thing about the anthracyclines. While in anti-HER2, trastuzumab, usually it's reversible. And if you re-challenge them with medications, then usually they go back. But with type 1 or anthracycline, if you re-challenge them, they will go into overt heart failure again, because as we said, it's irreversible. So if we come to LV function assessment, estimating LVF is not supported, and mainly this is because it lacks reproducibility, even intra-observer reproducibility. So the recommendation is to do 2D volumetric symptoms method, which is from two planes. 3D EF has superior reproducibility compared to 2D. However, it remains sensitive to image quality. And the 3D echo, many advantages. It's accurate, it's reproducible, it assumes no geometric assumptions, and it minimizes the foreshortening, and it's automated, which makes more reproducible. The main disadvantage that we have is it's, again, based on the image quality that you have. And if we see that the accuracy compared to the cardiac MR, it's very accurate with the 3D more than the 2D. So usually what we do when two contagious LV segments of any apical view is not seen well, usually contrast is recommended, and it should be given in every sequential imaging after that. And giving unknown effect of the 2D speckle tracking, contrast images should be obtained first before giving contrast. And since diastolic dysfunction can precede the systolic dysfunction, so in some patients, full diastology should be done at baseline and all sequential imaging. GLS and chemotherapy-related cardiomyopathy, I will not talk much about what it is because it's already covered by other colleagues, but I will say that strain is the change in the length of myocardium or deformation, and we usually take the longitudinal strain, not the circumferential or radial, because longitudinal strain has been validated that is very reproducible, unlike the circumferential and the radial strain. And the value have been like different in many studies, but generally a normal GLS is negative 17% in males and 18% in female. Generally, in adults, less than 16% is considered abnormal. 16 to 18% is borderline, and more than 18 is normal. And more than 15% change is known to predict subsequent decline in the EF. So first, this GLS story started a few years back, where small studies were going on to test the GLS in chemotherapy-related cardiomyopathy. But then Dr. Thavender Nathan had a systemic review in 2014, 13 peer-reviewed publication involving approximately 384 patients with anthracycline mainly. And they concluded, in absence of reduction of EF, GLS between 9 and 19% seems to be common during or immediately after anthracycline therapy. And they concluded also that early fall on GLS between 10 to 15% predict subsequent cardiotoxicity. But then this is the trial that the same guy published 2 years back, 2021, and it is the biggest and the only randomized controlled trial that we know in cardio-oncology. And it was international, multi-center, prospective randomized controlled trial, 331 patients treated with, they have one risk factor at least of heart failure, and they were allocated to either to have cardioprotective therapy initiation that is guided by either a drop in GLS or drop in EF, and they wanted to see whether those patients have, at the end, better systolic function. And at the end, 307 patients were analyzed in the study. And the majority of them were women with a breast cancer, and the primary outcome is, which is the change in the EF, was not significant between the two arms. However, in one of the secondary analysis, patients who received cardioprotective therapy in EF-guided arm had larger reduction than GLS patients.
2 minutes, Doctor.
Okay, so generally, there was, in this study, there was one thing that draws the attention. Fewer patients met the chemotherapy-related cardiac dysfunction in the GLS-guided arm than the EF arm. And this was a surprise because we thought that we will detect with the GLS more patients that is going to heart failure than those patients who were detected by seeing the EF. And also in this study, part of the definition is drop more than 5%, but those change could have been possibly by error. So the message from SOCOR trial, to the moment, we do not depend on the drop of GLS alone to start medical therapy, and we do not depend on drop in GLS as a sole factor to stop chemotherapy. Generally, we recommend referral to cardio-oncologist, and discussion between cardiologist and oncologist encourage if there is no cardio-oncologist in the institution. And further trial had to be focused on clinical endpoints. If we talk about LV diastolic dysfunction, this meta-analysis concluded that there are no data to support their use as a predictor for heart failure in treating the patient with heart failure, chemotherapy. And also RV dysfunction happens usually in RV biopsies that in those patients who are treated with chemotherapy. However, there is no data about it. Okay. I think probably this is the last slide.
Time is up. فيمكن علقت ال.
That's fine.
Thank you.
Thank you very much.
Thank you very much indeed for all the speakers. I think in the sake of time, there will be no discussion. We will conclude the session and we will move to the following session. Thank you so much.
شكرا يا دكتور، الله يكرمك. خلي بالك الشهاده الورقيه. تفضل دكتوره جميله. في الاخر اصلي هتبقى سريعه. الله يكرمك. الله يكرمك. دكتور مصطفى بتاعي. خليك هنا بقى عشان انت تشيل بيرسون دلوقتي.
هو انا الشيخ بس.
دكتور عبد المجيد.
عبد المجيد شيخ بس.
حبيبي الله يبارك لك. حضرتك وكان الفايد دكتور محمد الراوي. دكتور محمد الراوي. دكتور الراوي. دكتور سارة can you help us? لا 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 موجودة هنا.
في اول واحد منهم وبعدين زكريا.
التركيب اللي فين
عند الجدول انا خلاص على ما
عندك الجمال. جميلة.
الو.
جميلة اللي هي اول واحد منهم.
في عيادتي
كل واحد 12 دقيقة كيف على السريع.
من ورا. اوكي.
12 دقيقة.
طيب.
ما يحتاج اقول لك تضيع وقت. هذا اتس نوت امبورتنت. خلينا نديهم للدسكشن بس وشغل
ومفيش ديسكشن.
Hello, assalamu alaikum. We'll start the session by Dr. Minwar al-Majnouni. He's a consultant cardiology and echocardiographer, head of the HIS Implementation Steering Committee. He's the head of Saudi group of Echocardiography, and he will talk about neuropathy. Dr. Minwar.
Dr. Mustafa. Assalamu alaikum. I'm going to talk about a subject that is came late. I hope to just refresh our information regarding this subject. Constrictive and restrictive pericarditis. Actually, two entities, and it's a type of diastology dysfunction, actually. But usually we, sometimes we don't pay attention for the Doppler studies, and sometimes we miss to catch up with this finding. So today I'm just going to have, like, study together the causes and how to identify them by echo. So constrictive pericarditis is a pathological condition with encasement of the heart by thickened, fibrous, and sometimes calcified pericardium, with secondary abnormalities in the chamber filling. Constrictive pericarditis itself is a potentially reversible cause of as I said, diastolic dysfunction, and there is three conditions resembling this condition: tricasp valve, regurgitation, and restrictive cardiomyopathy as well. So the clinical picture is heart failure, but the finding is different. So we need to be precise to identify the cause of this diastology. Remember, usually when we talk about constriction and restrictive, we have to think about two things. One is, in case of constrictive, it is a stiff wall. What I mean is the pericardium is so stiff that restricts the filling of the cardiac cycle during diastology. While in the restrictive dysfunction, it is in the muscle itself. So total different in the pathophysiology of this. But both of them lead to a reduced filling in diastology. That's why the preload is affected, so the afterload is affected as well. So etiology, when we study the constriction, we think about many causes like, infection, cardiac surgery, radiation, and so on. Dr. Lang and his group, they studied the causes in two periods, actually. They divided two groups and finding what's the reason behind this situation. The first group this is retrospective studies. They want to find what the cause behind this. So in 1936 to 1982, they found that the most common cause of the constriction is infection. Okay. And the second was the radiation cause. But in 1985 to 1995, they found that the first cause is idiopathic, and the second place came the surgery, post-cardiac surgery. And so on, the radiation and infection comes after. Now, it's the time of the echo. The first finding in the 2D in diagnosing the constriction is what we call it ventricular interdependence. And this, you can see it very clearly by 2D of the getting the fourth chamber. Sorry. Go back. As you can see, sorry. Yeah. As you can see, the interventricular septum, an inspiration move to the right, left ventricle, and expiration right ventricle. And as well, you can find this finding by doing the M mode of the left ventricle. As you can see, the ventricular septum moving with inspiration toward the right ventricle, and with to the left ventricle, and with expiration to the right ventricle. And again, you can find it what we call a septal shudder, which is a septal diastole shudder consistent with the septal bounce seen by the 2D. Step 2, you will do the Doppler study of the mitral inflow, and you can see the variation of the flow, and this variation, it has to be more than 25% of the normal. with the respiration. So the point of to have diagnosis of this, you need to set up the spirometer with the Doppler study. It's very important. The third step is to make the tissue Doppler of the medial mitral annulus and the lateral mitral annulus speed. So you'll find in the medial mitral annulus tissue Doppler demonstrate elevated E prime despite increased filling pressure, and we call this annulus paradoxus. While the lateral mitral annulus speed, it is less than the medial, and we call it annulus reversus due to the lateral tethering of the part of the mitral annulus because of the constriction. The tissue Doppler, as you can see again, it is the same. You see that the lateral is less than the medial. And the other point that can give a clue of the constriction, you might find the thickening of the posterior wall by the 2D, and if you did a chest X-ray, you'll find a calcified pericardium. Next step is doing the Doppler of the hepatic vein and inferior vena cava. You can find inferior vena cava dilated, fixed dilatation with loss of collapsibility. And when you study the Doppler velocity of the hepatic vein, you can see, as you can see, the D signal is less than with the expiration, the flow is less than the inspiration. So there is a variability during the inspiration and expiration with the atrial reversal signals with expiration. And Doppler over the pulmonary vein as well, as you can, it's as well as the mitral annulus flow. You'll find variability of the filling of the pulmonary vein. Sometimes you suspect the constriction, but it's not obvious with the mitral flow, and you might do this maneuver, sitting position, and you measure check for the variability of the flow over the mitral in the sitting position. So, is the tamponade caused by pericardial effusion gives the same picture of constrictive pericarditis? There is? How far similarity? Is it the same or different? Because both of them there is constriction, right? There is a restriction of the filling. Well, tamponade in the physiology resemble the constriction, but it differs. With the constriction, early diastolic filling is rapid, but end abruptly when the volume limit, the rigid pericardial space are reached. While in tamponade, the diastolic filling is impaired in both early and late, as you can see. Restrictive, the second entity of studying the diastology is restrictive cardiomyopathy. And as I said, restrictive cardiomyopathy is a primary disease of the myocardium itself, and it's caused by abnormal elastic properties of the myocardium or intracellular matrix. The presence of abnormal left ventricular diastolic filling associated with intracellular and or interstitial infiltration or fibrosis in the absence of LV dilatation. We have many causes for causing the restrictive cardiomyopathy. We have familial and genetic disease and non-familial, non-genetic disease. The familial, like the sarcometric protein mutations, familial amyloidosis, and so on, primary hemochromatosis, and glycogen storage disease. Non-familial, we have the amyloidosis, which is acquired, idiopathic, and sarcoidosis, scleroderma, hypereosinophilic syndrome, idiopathic, and drug like methyl sergide and ergotamine, and so on. Carcinoid is one of the causes of the restrictive cardiomyopathy as well. Metastatic cancers as well, radiation, chemotherapy. We'll come to the point of diagnosing the restriction by echo. One of the hallmark of diagnosing the restriction is the typically cardiomyopathy characterized by a marked dilatation of both atrias in the presence of normal or mildly reduced LV function. As you can see, the mitral flow is having distinctive increase of EA ratio. It should be more than 2, with short E wave deceleration time and mostly less than 150. The lateral mitral annulus, as you can see, the speed is very slow in compared to the other type. It should be less than or mostly less than 5. And as you can see here, it is 4 centimeters per second. In hepatic vein Doppler, as you can see, the diastolic variation with respiration. Can you give me 1 minute? Just 1 minute. Wasta.
I think time is up, so just
30 seconds. I want to put just 30 seconds.
Okay, 30 seconds exactly.
If you have mitral inflow ratio more than 8 and dilated IVC, so this is unlikely to be, if you don't have it, unlikely to be constriction or restriction. If you have it with ventricular septal defect, you need to measure the E prime over the mitral. If it is more than 8 centimeters, it is constrictive. But if it is 6 to 8, this is mixed. You need to do further testing. And lateral, if it is less than the medial, so this is mostly constriction. And if the hepatic vein dilated more than 8, so it is definitive constriction.
Thank you very much. I think we'll move to the next talk, which will be virtual. Dr. Kostas Babadbilios from Greece. He's going to join us. He is well-known in the field of echocardiography in Greece. He has been published many publications. He had been certified. Dr. Kostas, are you with us? We can't hear you. Unmute yourself, please. Is he with us online? Dr. Kostas, can you please? We still can't hear you.
We'll skip him until I chat him. I'll have a chat with him. We'll go for Ms. Huda.
For the third? Yeah. Okay, till we sort his connection, we'll go to move to the next speaker, Dr. Huda Shhata. Dr. Huda is a consultant echocardiography from Alexandria, and has been worked before, and she got her PhD from Padua and King College. She's going to speak about the role of 3D in left atrial appendage closure. So, Dr. Huda, the floor is yours. Please stick to the time of 12 minutes. I knew in the schedule all of the speakers supposed to have 15 minutes, but this is the recommendation of the organizing committee.
Okay, I'd like to thank our dear Professor Dr. Ali and the El Moussa Hospital for the great invitation to be sharing in that great Congress. So my talk today I'm going to talk about the role of echo in assessment of patients going to do percutaneous left atrial appendage occlusion. First of all, I have nothing to declare. So here we are going to talk in my presentation about the role of TOE in assessment in those patients. We have to understand the anatomy of the left atrial appendage. We have to understand the proposed TEE protocol and the imaging views. What is the role of the transesophageal echo in assessment of the left atrial appendage, the procedural guidance and the possible complication, and finally what we have to do in the follow-up of those patients. First of all, the left atrial appendage actually has its own personality. It has multiple common nominations. We have the windsock type, and also we have the chicken wing, the cauliflower type, and also we have the cactus shape, which is more described in the cardiac CT. However, this is not important because sometimes we have atypical or non-identified shapes of the left atrial appendage. Sorry, please. It's a freeze. It's not going on. Yes. What's more important, the left atrial appendage, is to know the number of the loops because it's a complex multi-looped structure, to know the anatomical boundaries, what are the imaging plans, to rule out presence of clots and to assess the contractile function using the emptying velocity. First of all, here all of us use TOE for assessment of the left atrial appendage. As we can see here, the blue rounded circle at the bottom of the image, this is where the TOE probe sits. Here we can see that the left atrial appendage is the furthest away structure away from the probe of the transesophageal echo. It's sharing common boundaries with the aortic valve, aortic root, mitral valve, and also with the left superior pulmonary vein. In another imaging plan here, we can see this is the probe of the transesophageal echo, and again, when we scan the left atrial appendage from this plan, we can see here that the left atrial appendage is correlated with the left upper pulmonary vein and with the pulmonary artery, as seen here in the CT. So there is liability for perforation, sometimes in laterally located left atrial appendage of the pulmonary artery. Here, what are the different parts of the left atrial appendage? Here we can see this is the ostium, and this applied to any shape of the left atrial appendage. This is the ostium or the orifice of the left atrial appendage, and then come the landing zone, which starts at the important landmark, which is the left circumflex artery here. And this is important for determining the size of the left atrial appendage occluding device. And the distance from the orifice to the landing zone, this is the neck of the left atrial appendage. And finally, which is important for choosing the size of the Watchman device, is the depth of the left atrial appendage, which starts from the landing zone to the apex of the left atrial appendage. So, what are the important landmarks that I have to check before going for left atrial appendage occlusion? First, which is the Commoden ridge or the warfarin ridge, limpus or Q-tip as it's called in Australia and USA. This is the lateral boundary of the left atrial appendage, and usually it separates the left atrial appendage from the left upper pulmonary vein. Here, this is formed the superior ridge of the left atrial appendage as seen in the 3D echo. And also one of the fundamental boundaries of the left atrial appendage, which is the left circumflex artery originating from the left main coronary. And this is an important landmark for assessment of the landing zone, as we will show later on these slides. Also, we have here the mitral valve here. It's important that the device is not impinging over the mitral valve leaflets. And this is the interatrial septum, which is important for the transseptal puncture when introducing the device. So there are 4 specific planes in the TOE to look at the left atrial appendage. The first one, which will be at 0 degree. Here we can see this is the most anterior view of the left atrial appendage. We can see the aortic valve and the pulmonary vein here. And one of the most important, and this is the most important view to assess the size of the device, the landing zone and the depth of the left atrial appendage will be at 45 degrees. Here we can see clearly the left circumflex artery, the common ridge, and here we can see the maximum long axis, and we can assess the depth of the left atrial appendage. Also at 90 degrees here, we can see that the aortic valve will disappear and mitral valve come in view. We can see the common ridge, the pulmonary vein and pulmonary artery. And finally, the next important view to assess the left atrial appendage will be at 135 degrees. Here we can see that the orifice here has a different size from the orifice here, as we will see later on. And we can see the circumflex appear, the common ridge and the pulmonary artery is correlated well with the left atrial appendage. So, what is the important view that we are going to use during implanting our device? We have to use the X-plane or the biplane mode if you have a 3D-enabled machine. Here at 45 degrees, we can see this is the lateral boundary of the left atrial appendage formed by the common ridge, and this is the medial boundary containing the left circumflex and the lateral annulus of the mitral valve. In the other orthogonal view, we can see the left atrial appendage in anteroposterior direction, and it's related to the pulmonary artery. Actually, this is a standard view to assess the landing zone, the ostium, and the depth of the left atrial appendage. Why it's always, it's a freeze again. It's not working. لسه تحت خلصنا كل ده كمان. Oh yes. Okay. Let's go for the procedural guidance here. The TOE is a standard technique that's used to rule out thrombus. Be careful because the patient referred for left atrial appendage occlusion, they are usually not properly anticoagulated because either they have contraindication to anticoagulation or they have bleeding complications. So look carefully for thrombus in these patients. You can use the biplane or X-plane. You can use the color Doppler flow, but be careful that you should lower the color scale because it's a low flow chamber. Use the emptying velocity at the orifice of the left atrial appendage. Use contrast and give time for the contrast to fill inside the left atrial appendage. And also we have to check it. لا في حاجة. شكرا. Look carefully in these patients. You have also to rule out, especially in patients with dense spontaneous echocontrast or left atrial appendage, sludge or mud inside the left atrium or appendage. Be careful in those patients because sometimes you have a clear appendage. However, we have a large thrombus, like in this patient, hanging over the roof of the left atrium. This is a patient that has a large left atrial appendage thrombus here, seen in different plans and in the MPR. And also, this is the most huge left atrial appendage thrombus I have ever seen. This is actually not patient referred for left atrial appendage occlusion, but the patient came with prostatic mitral valve thrombosis, and we accidentally discovered this huge thrombus inside the left atrial appendage. So the most important part in this lecture is to what about the device sizing in those patients? We can do device sizing using 2D or 3D TOE or cardiac CT. If we are going to use the 2D TOE to size our patients or occluded. In amulet type here, the standard view is at 45 degrees. We have to obtain 3 measurements, which is the orifice here, which is stand at the ostium of the left atrial appendage, and then we go from 10 to 12 millimeter inside the depth of the left atrial appendage, or the best is to start at the left circumflex artery and we go across the appendage to the other side from 1 to 2 millimeter inside the appendage, and this is the landing landing zone, and it will determine the size of the device that I'm going to use. And finally, the depth of the left atrial appendage, and it should be from 10 to 12 or 15 millimeter in length. This is regarding the amulet type. What about the watchman type? In watchman device type, here we forgot or we ignore the orifice measurements. We have to do two fundamental measurements here, which is the landing zone at the level of the circumflex artery, like in patients going with amulet. But the most important here that we measure the left atrial depth. And in patients going to have a watchman device, we should have a depth which is equal or greater than the landing zone in those patients. So this is using 2D. What 2D transesophageal echo? What if I'm going and I have 3D TOE? Be careful, because 3D TOE is important in those patients because the orifice and the landing zone, as we can see here, it's not a quite well circle. We have an oval shape with maximum and minimal diameter. Also, we have a spiral configuration. As we can see that the upper border here at the limbus has higher level and goes spirally downward to the inferior margin. So we have different plans at the ostium of the left atrial appendage. So here the 3D transesophageal echo can help to avoid undersizing of the device. So with the help of the 3D MPR, we can assess the left atrial appendage orifice here and get the maximum and minimal diameter. And also with the help of the multiplanary formatting, we can go down at the level of the circumflex artery and get the maximum and minimal diameters of the landing zone. So which diameter I should use in those patients, the maximum, the minimum, or the average? Actually, it depends on the type of the valve, of the device. If I'm going to use amulet, okay, okay, هتقف ولا؟ okay. If I'm going, sorry, oh, okay. If I'm going and I obtain the maximum and minimal diameter, if I'm going to implant an amulet device, I will take the average of the maximum and minimal diameter. But if I'm going to use a watchman device, I usually oversize by 10 to 20% of the actual size of the left atrial appendage. So we choose the maximum diameter to get the size of the watchman device. Here is there are available charts and tables for appropriate sizing, but be careful. According to the last consensus on the catheter-based left atrial appendage occlusion, amulet device is not used if the patient has a landing zone more than 31 millimeter, and if the depth of the left atrial appendage is less than 10 millimeter. So what about the watchman device? The watchman device, we have to be careful, as we mentioned, that the left atrial appendage device, watchman device, cannot be used when the left atrial appendage depth is less than the diameter of the landing zone. When we go the next step, here we choose our device. We have to go to the transseptal puncture to go to the left atrial appendage. And we know, all of us, that the left atrial appendage is an anterolateral structure. But in some patients, it can be more laterally or more anteriorly oriented. In those patients, how I know that it's more anteriorly directed, more than being laterally directed? When we see the long axis of the left atrial appendage and the aortic valve in view, this means that this left atrial appendage is more anteriorly directed. So I have to puncture the septum more posteriorly. And if I have the maximum long axis of the left atrial appendage while the mitral valve in view, so this means that the appendage is more laterally directed, so I have to puncture the septum in the middle or a little bit anterior. Here, this is again the standard view for the transseptal puncture. I have to obtain a standard bicaval view, the superior and inferior vena cava, and also the short axis view with the aortic valve in view. This is the anterior and this is the posterior part. Here in the superior inferior configuration.
دكتورة هدى المحاضرة رائعة ومستمتعين, but we have really to.
Okay, thank you.
قولي لنا لا قولي لنا message take home في ثانيتين.
Take-home message TOE is the standard technique actually to size the device that I'm going to implant regarding the type and the size of the device. So this is important in guiding the procedures, rule out complications, and also in guiding the transseptal puncture. And also it's important to be in the posterior and inferior part of the interatrial septum. Follow-up imaging of those patients is important because they have sometimes leaks to check at the 3 months, 6 months, and 12 months. Thank you.
شكرا جزيلا دكتورة هدى. Do we have Dr. Costas with us? Dr. Costas, how are you? Thank you very much. Can we? Yes, we hear you, but we don't see your slide. Take your time. I already introduced you to the attendee here.
Great, great.
Now we can see you and we can see your slide. Just put it in the show mode. Great. Thank you very much. You can go ahead now. The floor is yours.
Thank you. So I'm honored by your invitation to attend this Congress, and congratulations for the nice topics. In 15 minutes, we will talk about how to assess the mitral valve with stress echocardiography in this lecture. These are my disclosures. So we all know that with 3D echocardiography, we can appreciate large anterior, one smaller posterior, the scallops, and have this nice surgeon's view of this mitral valve. And we should all know this Carpentier classification, distinguish the primary from secondary MR, and know the pathophysiology of mitral regurgitation in order to have a common language. There are standard methods for quantification of the severity of MR. We usually go with the PISA method to measure the recursive orifice area and the recursive volume, but we should also use the color Doppler, the vena contracta, the pulmonary veins flow for systolic reversal, and if we have a 3D probe, then we can also measure the vena contracta area. In the last ESC guidelines for valves, we know that the threshold for severity of MR is equal in primary and secondary MR, and now we should report a severe mitral regurgitation only when we have an ERO more than 40 millimeters square. And of course, we should never forget the qualitative criteria of severe mitral regurgitation, for example, like a flail leaflet. In terms of management of these patients, we all know that if we have a severe MR and a patient symptomatic, then we should repair this valve, either surgically or with transcatheter edge-to-edge repair if the patient is high risk. And this is in agreement between ESC and American Society. But what happens if we have this subgroup of patients? A patient with severe MR but claims to be asymptomatic, or a patient with symptoms of heart failure and moderate MR. In these situations, we can use stress echocardiography because stress echo can answer questions like what is the severity of MR if the patient is truly symptomatic, what is the systolic function of the left ventricle, and what are the pulmonary artery pressures. Stress echo is not only for ischemia detection, we can also use it for non-ischemic heart disease. This is a consensus document from ECBI showing that we have an algorithm where we can use exercise echo in patients with discrepancy between the symptoms and severity of valvulopathies. And in primary and secondary MR, the indications for exercise stress echo are symptoms disproportionate to MR severity, recurrent and unexplained pulmonary edema.
Dr. Konstantinos, can you please come closer to your microphone? Because we are having difficulty to hear you. Great. Yeah, you can speak now. So.
Yeah, what about now?
Yeah, I think it's better. Go ahead, please. Thank you.
Okay, so I was saying that the indications for stress echocardiography in primary and secondary MR are symptoms disproportionate to MR severity, recurrent and unexplained pulmonary edema, patients with moderate MR that undergo a CABG, bypass surgery, and persistent pulmonary hypertension in patients after mitral valve repair. We should all know that 1/3 of the patients that claim to be asymptomatic usually modify their habits and lifestyle in order to avoid their symptoms. This is something that we should know for all asymptomatic patients. In our lab, we have a supine bicycle, and this is the stressor of choice because with supine bicycle, we have a reduced risk of hemodynamic collapse. We can have continuous echocardiographic examination throughout all stages. Cycling is more isometric than walking on treadmill, and the patient remains at the same position throughout the whole examination with echo. There are several protocols for exercise echo, but all of them agree that if we use an exercise echo with bicycle, then we can have 2-minute stages of 25 watts each stage, and in every stage we should assess the left ventricle diastolic and systolic function and wall motion abnormalities, the right ventricle, the mitral valve, either MR or mitral stenosis, the E2E prime and diastolic dysfunction, the TR velocity and the pulmonary pressures of these patients. All these measurements should be done in every stage during stress echocardiography. Parameters of poor prognosis in primary MR are increase of MR grade more than 1, pulmonary systolic pressure more than 60, absence of contractile reserve, which means less than 5% increase of ejection fraction and less than 2% increase of GLS, and limited RV contractile recruitment, which means that TAPSI less than 19 millimeters during exercise. And in secondary MR, parameters of poor prognosis are increased in ERO more than 13 millimeters square and significant pulmonary artery pressure during exercise. Reserve of the patient, measure the ejection fraction during exercise and the GLS. The patients without contractile reserve are the ones that had major events and patients with less survival in a period of 3 years follow-up in this paper. And of course, right ventricle is also important. Right ventricular dysfunction during exercise is very important because it is a prognosticator for poor prognosis and survival, and prognosticator of heart failure hospitalizations in these patients as well. In secondary MR, a difference of ERO more than 13 millimeters square is important because this can show the heart failure admissions of these patients and the survival as well in secondary MR. Pulmonary hypertension should also be measured in patients with secondary MR. You can see in this slide that the patients that develop severe pulmonary hypertension are the ones that have increased major adverse events, hospitalizations, and decreased overall survival. So all these are included in the new guidelines from ESC for valves, and in these guidelines, the stress echo is used in primary MR in order to unmask the symptoms, or if we have difficulties in diagnosis with the resting transthoracic echo. And in secondary MR as well, stress echocardiography can be used if the resting echo is inconclusive. So let's check some cases, different clinical scenarios, patients that came to our lab for exercise stress echocardiography. So in the first case, we have a 70-year-old female patient, smoker with diabetes mellitus, a recent inferior STEMI with primary PCI, moderate ischemic MR with akinesia of the inferior wall, and heart failure symptoms of NIHA class status of 3. The baseline transthoracic echo showed the akinetic inferior and inferolateral wall and a moderate MR with normal pulmonary pressure. So the patient was referred to our department for exercise echo. At rest and baseline transthoracic echo, you can see a preserved ejection fraction, a moderate MR, diastolic dysfunction grade 1, and ERO of 10 millimeters square, a GLS of minus 16.7, and normal pulmonary pressures. So we did exercise echo, and at the second stage, in 50 watts, you can see that we had a significant mitral regurgitation with an ERO that was increased at 30 millimeters square. We had significant LV filling pressures. The patient was symptomatic, but we didn't have severe pulmonary hypertension, and we had a very nice contractile reserve with GLS of minus 19%. Since we did a TOE in the patient, we saw that the valve has no anatomic abnormalities. We had tethering of the leaflet, so it was an ischemic MR only, but significant MR. But since the patient was very close to the STEMI, we decided to wait, see if we have a resolve of this akinesia of the inferior and posterior wall, and if the tethering becomes better throughout the follow-up visits. So the patient came 6 months later. You can see that the wall motion is better now, and the patient felt better as well. She was on NIHA status 2, and the MR was still moderate. It didn't increase, so we decided at the moment not to do anything in this patient and just watch and wait. In another clinical scenario, a young patient, 49 years old, with heart failure symptoms, shortness of breath, NIHA class 3 status. He came for a transthoracic echo. We saw that we have a prolapse of the posterior leaflet, normal pulmonary pressures, increased LV filling pressures, so we decided to do an exercise echo in order to evaluate the MR severity and the pulmonary pressures of this patient. You can see at the baseline transthoracic echo that we have this very eccentric jet of the MR. We have a prolapse of the posterior leaflet, a coaptation gap, which means that probably it is a severe MR. The TR velocity was 2.8, and the ERO was measured at 10. Again, we underestimate the ERO when we have that eccentric regurgitant jet. We did an exercise echo. We saw that the PISA radius and the ERO was measured at 40 millimeters square. We had a TR velocity of 3.4, a restrictive pattern of mitral valve inflow, systolic reversal in pulmonary veins. So we confirmed the presence of severe MR, and the patient was symptomatic at a level of 100 watts with contractile reserve also, and the normal right ventricle. So we did a TOE, and we saw that we had this flail P2 scallop with ruptured chordae of the posterior leaflet. So the patient underwent a surgical mitral valve repair. Another symptomatic patient now, an old male, 76 years old, symptomatic heart failure symptoms with moderate degenerative mitral regurgitation due to prolapse of the posterior leaflet, normal ejection fraction, normal pulmonary pressures, normal LV filling pressures. So does he have symptoms due to the MR or not? We did an exercise echo again in this patient. You can see here that we have an enlarged left ventricle, an eccentric jet of MR in this patient, normal E and A waves, TR velocity 2.4, and at stress we couldn't appreciate the ERO because the jet was so eccentric, but we had increased LV filling pressures, and the TR velocity went up to 3.7. The patient was symptomatic in 50 watts very early, only with 2 minutes of cycling. So we did a TOE, and we saw that we had this multiple chordae ruptured at the level of P2 scallop, and this prolapse of the P2 scallop. So we decided with this symptomatic prolapsed valve to proceed to surgical mitral valve repair. Sometimes you might have a young patient like this male, 52 years old, with severe MR, flail leaflet. He claimed that he didn't have any symptoms. He didn't want to do anything for the management of this valve. So he came for an exercise echo in order to unmask the symptoms or not. You can see at the resting TTE that we have a flail posterior leaflet, significant MR, severe, and pulmonary pressures 2.6. With 75 watts of stress, we can see that we had severe MR, severe TR, restrictive pattern of mitral valve inflow, and TR velocity 3.9. The patient was really symptomatic. We had to stop this exercise. So he was convinced to undergo a TE. And you can see here again the flail P2 scallop with multiple chordae ruptured. So the patient underwent surgical mitral valve repair. Sometimes we can have a non-obstructive hypertrophic cardiomyopathy case.
Dr. Constantinos, we have only 1 minute, please.
1 minute, yes, I will conclude. In this case, sometimes if you have a hypertrophic cardiomyopathy case, then you might have to answer if the patient has only diastolic dysfunction or MR. You can see here that this patient with exercise echo and mild MR with stress, we had a TR velocity of 3.5 and this systolic anterior movement of the anterior leaflet and this significant MR. But in this kind of patients, we only go with medication or with transcatheter edge-to-edge repair, and we don't repair or replace the valve. Finally, in less than 1 minute, I will just tell you that when we have a mitral stenosis, the cutoff values for significant mitral stenosis in exercise are 15 millimeters of mercury in exercise echo, or if we use dobutamine, then the mean gradient of mitral valve should go in 18. Like in this patient, you can see the rheumatic mitral valve with doming of the anterior leaflet, and a mean gradient from rest at 7, it went up to 22 with 2 minutes of exercise in a symptomatic patient. So this was confirmed, of course, with TE. Flexi slice measured the mitral valve at 0.9 centimeters square, so it was a confirmed severe mitral stenosis case. So I conclude with this slide saying that exercise stress echocardiography is very important for the timing of intervention, and very important when we have discrepancy between the symptoms of patients and the severity of valvulopathies. And when we do a supine bicycle to our patient, we should not only examine the mitral valve, but also the left ventricle, the right ventricle, the TR velocity, and the pulmonary pressures. Thank you very much for watching. I hope I was in time. And I would like to welcome you all in our Imaging Congress in Athens, 31st of March. Thank you.
Thank you very much for this excellent lecture. We are looking to see you in Greece in next 2 months. Do you have any question? Yeah, go ahead, please.
Thank you for this nice, attractive lecture. I would like to ask about the priority of mitral regurg. If you see the second and third case you were present, the patient has flail. I think the T is priority, and we cannot. There is no clear guidelines about evaluation of the severity for intervention by stress echocardiography. This is my concern about this presentation.
From our experience, we can understand if we have a severe MR, because if you see a flail leaflet, then in my opinion, you don't need to do exercise echo. But sometimes, if you have a patient that says that he doesn't have any symptoms and he's young, then these patients are very difficult to convince to proceed to surgical repair. And in these cases, the bicycle helped me to convince them that they have problem. They don't do what they used to do 1 year or 2 years ago. So, of course, in guidelines, it's not a priority. You cannot choose how to go step by step. But if you ask for my opinion, if you can see a flail leaflet, go for a TOE and surgical repair. But if you have a difficult patient, then you can convince him and mask the symptoms with a bicycle and then proceed to the TUE.
Thank you very much. Have a good day and see you inshallah at the next meeting. Thank you.
Congress, and thank you for the invitation.
I think the next speaker is Dr. Reem Al-Badr. She is a well-known consultant, professor of pediatric cardiology at King Abdulaziz University. Dr. Reem, she will talk about aortopathy in adult congenital heart disease.
Bismillah. Hello? Okay. Bismillah ar-Rahman ar-Rahim. Thank you so much for staying so late. And I'm really grateful, despite all what's happening, you're still staying. And I want to thank Dr. Ala for such a beautiful gathering. We haven't seen each other for 2-3 years or more than that since he stopped doing the ECHO meetings. Alhamdulillah, he's back. And also I want to thank Dr. Abdullah Al-Farhan for his really a lot of help and support to all of us. I'm going to switch gears to a different theme, which is the pediatric side of the disease, which is also the origin of all diseases that you see, most diseases that, congenital diseases that you see in adult life. So I have no disclosures. The definition, adults with congenital heart disease fall into 2 categories. One is that patients who have been recognized, treated, and followed during their pediatric years, and then we hand them over to you, or de novo previously unrecognized adults who may or may not be symptomatic at time of diagnosis. So we have 2, either follow-up or de novo. Now, prevalence and risk factors, congenital heart disease in the adult is now more prevalent than ever because of rapid advances, surgical medical interventions, because we are really doing a lot of preventive medicine, a lot of sort of scanning and so on. Now, this is very important. Now, there are now an estimated 750,000 adults with congenital heart disease in the US alone, and this statistics is not updated. Now, this is excluding the bicuspid aortic valve, which is very important. And I see even bicuspid aortic valve in utero. But we don't really say this is the commonest congenital heart disease. I don't know why. It's about present in the 2% of population. For us, the commonest congenital heart disease is VSD or PDA. And so we have bicuspid aortic valve and we have mitral valve prolapse. Prevalence and risk factors, most congenital heart disease appears to be caused by genetic abnormalities. Now, with the whole exome sequencing and a lot of genetics going on, most of the diseases will carry genetic origin, but there's difference between genetics and inheritance. We have to know that. So evidence to support importance of genetics in congenital heart disease includes much higher risk for offspring. Always mothers ask about, what about my kids? I have tetralogy. Will I get a child with tetralogy? I have transposition. I had transposition. Now, we're not talking about acquired mitral stenosis, secondary traumatic heart disease. That's not part of the spectrum at all. Now, we always go and research into, we know that the incidence of congenital heart disease is 8 per 1,000, but in Saudi it's around 12 to 16 per 1,000. It's not documented, but 2 centers already published their data. And we have higher incidence of congenital heart disease because of the consanguinity that we have. Now, we know about familial congenital heart disease. This is very important. So there's difference between inherited heart disease and familial. Familial is more than just inherited. So it comes in the family because they don't, مو زي الرسول صلى الله عليه وسلم قال غربوا نكاحكم. They keep in one family or one tribe or whatever. Especially among the rich people, they don't want the money to go outside. It happens a lot. They keep giving their children. Now we talk about the common clinical syndrome. So please note that chromosomes is not always genetic. These are terminologies that we know as pediatricians. So we have 21, trisomy 21. We have 60% of trisomy 21, they have congenital heart disease, which is atrioventricular receptor defect, the majority. So if in a fetal life I see AV canal, I refer the mother for genetic testing, for chromosomal analysis, for trisomy 21, and vice versa. If there is a fetus with trisomy 21, we have to do chromosome, we have to do heart. So we work as cardiologists and phytologists, we work very much with families and congenital heart disease. Anyhow, in general, routine screening of adults for genetic mutations is not currently advocated. It's not cost effective, okay? Especially in the West, and we follow the West. We don't have anything for the Middle East area or for the Gulf, where we say we have lots of things going on, cardiovascular diseases and long QT syndrome and familial long QT syndromes now, and I think in King Faisal they have a registry for that. But it's not all over the area. Pathophysiology. Now, we know that clinical course of congenital heart disease in the adult is most dependent on the anatomic lesions. What does this mean? If I have transposition of great arteries operated on the adult will look normal. His saturation would be around 92 to 94%. If I have a single ventricle and she's 22, and she has a Fontan and her, without fenestration, her saturation will be around 98, 94. With fenestrated Fontan, her saturations will be around 85 or 84. So it depends on the etiology, okay? Please don't consider mitral stenosis, mitral regurg, and rheumatic heart disease as part of the spectrum that I'm discussing. Now, lesions, we know that 3 general categories, just to refresh your memories, because you left the pediatrics long time ago. We have simple shunt lesions like ventricular septal defect, patent ductus arteriosus, and so on. We have obstructive lesions, like aortic stenosis, pulmonary atresia, and so on. We have complex lesions, acyanotic and cyanotic. Cyanotic, we all know about the obstructive right heart, obstructive left heart. Acyanotic, we have like AV canal. Most of the time it could be cyanotic, but very little cyanosis or total anomalous pulmonary venous return, and so on. These can be missed. Now, genetic aortopathies. We're going to focus on the aorta now, and we talk about the genetic etiology of aortopathies that you see in adult life and we deliver to you. So we have, as we said, autosomal dominant, which is Marfan. Autosomal dominant means mother and father are carriers, 50%. And with every delivery, there is 1 in 2 chance that the baby will carry the disease, so 50%. So when we counsel a pregnant mother with a Marfan syndrome fetus, we say, with a fetus, we say there's a 50% chance that your baby will be a Marfan. Marfan, Ehlers-Danlos, and Lewis-Teeth syndrome. So remember Dr. Hani Mahmoud was showing his fingers and he was doing like that, and somebody asked him if he is a Marfan syndrome or connective tissue, because they have elasticity, and not every Marfan is I mean, we have lots of them. Marfan, Ehlers-Danlos, and Lewis-Teeth, they are connective tissue disorders with increased elasticity, but have other phenotypes with it. Aneurysms of the osteoarthritis syndrome and Turner syndrome. Chromosomal these are the short ladies with XO, so they don't have a Y, so I have a 0 or instead of the Y. So it's instead of the X, sorry. XX, you had XO. And these are short women, and these are chromosomal abnormalities. Any lady below 150 should be screened for Turner syndrome, and you usually do a buccal smear, and it's very easy to diagnose. Non-syndromic familial thoracic aortic aneurysms and dissection. So non-syndromic because in children we have lots of syndromes, lots and lots of syndromes, and when we say syndromes, it doesn't mean that these are inherited things. These are just phenotypically with structure abnormalities, constellation of symptoms, and we call it syndromes. So non-syndromic and familial. So familial is very important, that you have the children and the offspring of 1 or 2 generations with the same disease. Just if you didn't see Marfan, 1896, he discovered the 5-year-old with a hereditary disorder. The word hereditary means he went into the history, and a good doctor will always go into the history details, and as pediatricians, we take a lot of history. I know adult cardiologists don't have time, but I think if you have the time, especially, and also as a fetal cardiologist, we talk a lot with the parents. History is very important in diagnosis. Marfan syndrome, you all know better than me, and we know that these are tall, and then the ratio between the upper and the arms and the upper and lower body is different. And incidence is 1 in 300 3,000 to 5,000. And there is no ethnicity or race, and this is very important in this genetics. We know that lots of mutations. So what does mutations mean? It means that you cannot diagnose a disease without having an index case. So you have to have a member in the family with Marfan, and then you can check the rest of the family. So this is the index case. So the mutation is FBN1 mutation and has been identified in 90%. Mutation in a gene means that the gene was okay, but something abnormal happened and it got mutated. So this is de novo mutation. It happens like that randomly. Now, in 75% of patients, we have autosomal dominant. So Marfan is autosomal dominant. So you counsel saying that if you get married, it's 1 in 2 chances with every child that this will be a Marfan syndrome, okay? Plus the features. Usually we depend not on the features nowadays, we depend on genetic testing most of the time. And 25% is mutation. So as we said, mutation, simply mother and father are normal. Though it's not carrying the gene from the mother, this is a mutation at a cellular level. The first fibrin gene mutation was identified in 1990. So now we don't go clinical a lot, we go more on genetic testing. So we said that this is the gene and so on. Pathophysiology, you don't need to know a lot of that, but we know that there's cystic medial necrosis. The word medial is very important in Marfan syndrome. Medial necrosis, the layer that is involved in it is very important, and this is a predisposition to dissection that happens in the coarctation or in the aortic dilation later on. Okay, now ectopia lentis syndrome. So not everybody with dislodged lens is a Marfan syndrome. We have other things. You have to do genetic testing. And this is a Marfan. So if you look here, you find that the hands, if you look the ratio of the hands extended will be equal to the ratio from the head to the symphysis pubis, which is not the usual thing. And when you ask them to put their hands down, you find that the hand is reaching to the mid-thigh, okay? And this is the hyperelasticity. So not everybody can do that, is a Marfan syndrome. Now, you have to have, as you said, index case and so on. And clues to diagnosis, family history, but remember there's something called de novo, and then you check the heart, and if you find that there's also Marfanoid syndromes. So not everyone who is aortic root dilation is a Marfan, or abnormal upper to lower body ratio is a Marfan. Go by genetics. So aortic disease, dilation of the aorta, and this is very important in pediatrics. When we see them, we give them a number, and then we put them in beta blockers before we hand them over to you. So this is a sort of aneurysm that can happen. As we say, cystic medial necrosis is behind this abnormal anatomy. And the frequency of Marfan syndrome is responsible for aortic dissection. This is very important. 50% of those under 40. So you have 50%. When you have aortic dissection below 40, think of Marfan syndrome. If you didn't know the story, 50%. 2% of those age 40 to 70, and over 70